You can either use the stage or if you want to be on the... اوكي. دكتور بالبيد ايش رايك؟ نقعد هنا ولا هنا ولا؟ خلاص اوكي. الله يحييكم على الستيج. So we'll have 10 to 15 minutes of question and answer, then we can go to the break. Unfortunately, Prof. Bahamam needed to leave earlier, so he's not going to be around. So any question from the audience? Dr. Muhammad. If we can have the mic, Dr. Hushaim.
السلام عليكم يعطيكم العافية جميعا. ما قصرتوا أبدا وثريتونا. محمد خشيم استشاري باطن وكبار السن. بصراحة very complicated and challenging topics you've discussed today. فتعلمت منكم الكثير. In particular, I guess my question is in regards to feeding and the NG versus PEG tube insertion. I think one of the biggest challenging concerns I have in my practice is when you have patients with terminal dementia and you have to discuss parenteral feeding with them. Even, I think taking a step back, our colleagues in swallowing teams and surgical teams insist on putting NG or PEG tube insertions. However, as you've showcased in your evidence today, that the mortality, there's no benefit, and there's more suffering, maybe more restraints and more complications. Any, I guess, commentary on how to discuss with patients, and before that, physicians and healthcare providers, on not to pursue parenteral feeding as much as possible? How would you convince them? Is it through the evidence you provided or some other means, perhaps?
So thank you for your question, Dr. Muhammad. It's a very common topic that we see every day in practice. And as you said, one of the issues that we face is when our colleagues put the patient on NGT, especially in ER, and he become more agitated, and when he landed in the ward, he'll be worse than he was. So I think one of the thing that we have to share the knowledge across all the healthcare worker in the hospital first, starting from the emergency medicine and other departments as well, all healthcare workers, physician, and others as well. The other for the caregivers, as you know, most of them, they, as Oriental people, and it is not only just in Saudi Arabia, most of the Oriental people believe that feeding is a way for comfort for the patient and for the family themselves. So sometimes, even if you told them, don't give them anything per oral, they will sneak something and you'll end up with the patient aspirating. So I think always you have to share with them the consequences of tube feeding or oral feeding, which is not appropriate, let's say, and try them to help you to reach that point. However, sometimes you will reach a resistant that they are insisting on putting a tube. And a recent research was published in the United States showed that big tube insertion was declined over the years remarkably after educating the caregivers and publishing the recommendation of other society, but still some patients get the big tube. My advice when they are insisting, I mean, it's better that you monitor that patient under your care rather than discharging him and he going to other facility and they will insert the tube and he land in your emergency with aspiration pneumonia or he will land in the ICU later on. So usually what we'll do, if they insist, we'll do it, but we will monitor the patient. As you know, most of the patient, if you insert, you have 48 hours to start the feeding. First you start with the continuous one. You will see that the patient will have a lot of secretions, and you can ask him, what color is it? They'll tell you the same as the feeding. So what do you think? Is it helping or not? Later on, they will tell you, you know what, stop the feeding. And this is where we reach when they are super resistant to our advice. But it's always multidisciplinary team decision where you sit with them and tell them the consequences and benefit. But this is always day-to-day practice. I don't know if anybody else from here.
Okay, sometimes giving like an option for the relative, it would be good for them. Like there is the first option just to start oral. A lot of patients, they are like getting oral supplement 5 to 6 to 7 per day, and they they are doing well with that. The other, they receive, as the doctor he said before, the big tube feeding. Sometimes they get like an infection in the big tube side, but they came again to the emergency to reinsert the tube. We do have both types of family who are accepting and the other not. Maybe in the practice, just the family sometimes they want to insert the tube. They feel like that would be much better for them because no one will take care. A lot of my patients, the drivers, they are giving the supplements. Sometimes they are skipping the meals, especially as Dr. Nabil said before about the comorbidities. A lot of them, they are diabetic, cardiac. So we must do something for them. We cannot keep them like on just good hydration. Maybe oral supplement or tube feeding will help them. And the convince, it must be individualized. The family, some of them educated, the other no. So, inshallah, it would be good for you.
So, thank you. Any other comments from the panel on feeding? Okay, we have another question. تفضل.
Assalamu alaikum. Sulaiman Kassar, Geriatric Fellow. I would like to thank Prof. Ahmed, Dr. Nabil, السادة دانيا, السادة حماد, Dr. Hashim. Thank you all. I have two questions, one for Dr. Hashim, one Dr. for Nabil. Starting with Dr. Hashim. هل في فئة معينة نقدر نوقف لهم الميديكيشن من المصابين بالزهايمر؟ I know I saw the research evidence, and what do you think about some people, could we stop the medication in certain time? Other question for Dr. Nabil. Do you recommend any specific time to refer the patient with Alzheimer for palliative care? Thank you very much.
شكرا Dr. Sulaiman. As I said, you're asking your question about the cholinesterase inhibitors and NMDA antagonists, right? Okay. Now, again, this medication has modest effect. It helps. And trust me, the non-pharmacological intervention as important as this medication and maybe more. So, unfortunately, sometimes we forget totally about non-pharmacological intervention, and we think that these medications are the only things or the only intervention for the patient. However, we offer the non-pharmacological intervention in addition to this medication, unless there is contraindication to use them. Otherwise, we introduce it gradually, start, for example, the cholinesterase inhibitors, then we add later on the NMDA antagonist, memantine. Now, our goal, our aim is to follow up the patient, and if I see the patient after 6 months, and I ask the family, how's your father or your mother? They said he's okay. So I ask him more specifically, is there any deterioration in the cognitive or functional status of your father or mother? They said no, they are okay, stable. This is a good sign. So I keep doing that every time I see the patient. And as far as the patient continue to be stable at home, no significant cognitive decline and no significant functional decline, I will continue this medication, of course, with the non-pharmacological intervention. However, if the patient gets worse throughout the course of the disease, and even you will hear it from the family, doctor, shall we discontinue this medication because my father is really getting worse and he's almost dependent in all ADLS. So at that stage, yes, we have to think about discontinuing this medication. Thank you.
Thank you. If there are any other questions from the audience?
I think
هذا شغال نبيل اللي جنبك.
Okay. Still, I think سؤال الدكتور نبيل. Okay, عفوا. أعذرني.
طيب, thank you, Dr. Sulaiman. For that, I think there is two concepts that you have to talk about it. Was the philosophy of a surface and the resources that we have. Meaning, in palliative care, we should caring of cancer, non-cancer patient, it's always better to see the patient as early as possible. The problem is that most of the time, we don't have the resources to cover all these aspects. So I think it is reasonable that when you think the patient is really reaching, I'll say, moderate to advanced stage, to refer the patient. If it is before that, that's okay. But anyway, usually the follow-up will be longer, like 6 months and 1 year for the clinic to be seen. However, I think as early as possible is better, so that at least we know the family, we know the patient, and we ask everybody, don't refer the patient when they are dying. This is not the way to comfort the patient, to palliate the symptoms, or even improve the quality of life. When they're dying, there is nothing much to do, just to treat the symptoms, and this is not the goal of the palliative care at that time. So as early as possible, putting in mind that sometimes the resources are not matching the philosophy that we have.
Thank you, Dr. Nabil. There's a question. تفضل.
السلام عليكم. عاصم الشنبري, geriatric medicine consultant. My question, Dr. Bender, regarding using the antipsychotic and anticonvulsant medications. As you know, like with those kind of behavioral problems that the patient would experience with the stages of the disease, would you please comment on the safety of those medications? And if you forced to start on something, on medication for antipsychotic, which one is better? Keeping in mind that sometimes that we are using it for the sleeping. Antipsychotic works for sleeping for most of our patients. Thank you.
Thank you for the question. It's really important because quite often we have to use these medications in the clinic. Like, as Dr. Hashim mentioned, like, non-pharmacological interventions, we start with them. But like, for example, in my practice as a geriatric psychiatrist, we get a lot of patients referred due to uncontrolled behavior. And so we have to start these antipsychotics. In general, we advise the patient's family that there's an FDA black warning on these medications, including typical and atypical antipsychotics. So the old antipsychotics and the new generation antipsychotics. But we tell them that the evidence for increased risk of death and pneumonia is still small. If we talk about statistics, it's like the absolute risk increase is 1%. But if we look into the numbers in terms of relative risk, it's 50% increase. So it goes from 1% to 2%. So this is the way that I discuss that with families, is that, there is risk, the risk of your father or your mother dying is 1% by using these medications. And they say, okay, but his quality of life is very poor now. We want something to to calm him down. He's suffering or she's suffering himself. So I'm okay with like 1% increase in risk, given that he is going to be more calm, less anxious. But we have to have this kind of discussion with families. In terms of the best evidence, like typically, we have the best evidence for risperidone as an antipsychotic. But the problem with risperidone is it has a lot of extrapyramidal side effects compared to other antipsychotics. Sometimes I use aripiprazole for patients who are over-sedated all the time. It could be more activating. Sometimes I use quetiapine for if the patient has significant sleep issues and behavioral issues. But as you mentioned that, sometimes we use them for as a sedative. I typically, I'm lucky at the National Guard Hospital, we have trazodone. So I use trazodone quite often. I prefer it over quetiapine. But if you have no choice except giving the patient medication, typically what I suggest to families is that give this medication for only a short period of time until the patient's sleep is regulated more, and then you can discontinue the medication. Quite often I tell the families that it's okay to wake your father or your mother in the middle of the day. I know it's hard for you to wake him up in the middle of sleep, but this is for his own benefit. So wake him up gradually and slowly, 30 minutes every 3 days. And then by doing that, you're making the sleep cycle back to normal. So sleeping during the night and waking up during the day. Anticonvulsants, we don't have really good evidence in general for behavioral symptoms. Sometimes we use valproic acid, carbamazepine, but the evidence is not very strong. We use them for patients who have, like, let's say, a history of prolonged QTC interval, and we feel the antipsychotics are less kind of safe. But now we have like some antipsychotics, they're having less propensity to cause prolonged QTC interval.
So just for the sake of time, I would like to thank the panel for their talks today and for the question and answer. They're going to be available as well around if you have any questions and answers. So thank you. And now we will break for lunch and prayer. Lunch is served on the first floor. And inshallah, we will reconvene at 1:15 p.m. for the second set of lectures. Thank you.